Hi everybody. Happy spring. Tonight I'm going to do two lectures. The first is going to be on laryngeal cancer, and the second one will be the introduction to the endocrine system. I thought that tonight was a good place to add in the laryngeal cancer, since you will be talking about malignancies of the respiratory tract. Laryngeal cancer. Tumors of the larynx may be benign or malignant. Laryngeal tumors are rare, but when they are malignant, they can be very devastating. However, with early diagnosis and intervention, laryngeal cancer is curable, and the ability to speak will be preserved. First, let's talk a little bit about benign tumors. There are three types of benign tumors. Papillomas, those are small water-like growths that grow on the larynx. There are nodules. Oftentimes they're called singer's nodules or vocal cord nodules. Nodules are always paired lesions on both sides of the larynx. They call them singer's nodules because a lot of singers wind up getting these nodules on the larynx because of projecting their voice. I don't know if you're all too young to have heard of Julie Andrews. She was in several musicals. She was Mary Poppins. She had to lose some of her singing range because she developed these nodules and had to have surgery. So there's papillomas, there's nodules, and the third type of benign tumor is a polyp. Polyps and nodules result from vocal cord abuse, such as chronic shouting to be heard. Singers, cheerleaders, public speakers, people in those types of work are more prone to benign vocal cord tumors than the general population. The patient with the benign tumor of the larynx presents with a breathless voice and hoarseness. Those are the presenting symptoms, breathlessness and hoarseness. Besides vocal cord abuse, cigarette smoking and chronic irritation from pollution are contributing factors. Malignant tumors. The risk factors are prolonged tobacco and or alcohol use. Prolonged tobacco and alcohol use are the two main causes of cancer of the larynx. The second reason, the second risk factor is poor nutrition and occupational exposure to industrial paint fumes, chemicals, and things like asbestos. So let's talk about the pathophysiology, or what happens with laryngeal cancer. Laryngeal cancer can occur in any one of three sections of the larynx: the glottis, which are the true vocal cords, the supraglottis, which is above the glottis, and the subglottis, which is below the glottis. Tumors of the glottis, or vocal cords, are the most common site. When the mucosa of the larynx is continuously exposed to noxious irritants like cigarettes, changes in the laryngeal mucosa begin to occur. White, patchy, precancerous lesions develop at first, and these white, patchy, precancerous lesions are called leukoplakia. Leuko, as you know, means white, like in white blood cells. As the disease progresses, red velvety patches develop, erythroplakia, erythro meaning red. Laryngeal cancer spreads by invading the surrounding tissue, or it may metastasize to other parts of the body. The good news, if there is any good news, is that laryngeal cancer tends to be slow growing. Can't remember, cancer of the glottis or the true vocal cords is the most common site. And you can see in the picture, I try to show where the different parts of the vocal cords are. So let's talk about the signs and symptoms of cancer of the glottis. Hoarseness and changing in the voice lasting more than 2 weeks are the 2 primary initial symptoms, just like with benign tumors. Voice changes and hoarseness occur because the tumor prevents the vocal cords from completely closing during speech. Other symptoms develop, but the tumor may be getting large when these actually show up. First is a sore throat, complaining of a feeling that there is a lump in the throat, difficulty swallowing or painful swallowing, difficulty breathing, foul-smelling breath, and a palpable lump in the neck. The person may complain of pain that radiates to the ear with a persistent earache and unintentional weight loss. Late in the disease, as the tumor enlarges, airway obstruction develops. As a side note, subglottal tumors, the ones below the vocal cords, are the least common type of laryngeal cancer. The subglottal tumors present with no early symptoms, so they're pretty dangerous. They don't show up until late in the disease. The diagnosis is based on the signs and symptoms. A laryngoscopy is done to view the larynx and to biopsy the lesions. The nursing care is the same as for a bronchoscopy. CAT scan, MRI, and chest x-ray will help identify the lesions, and a needle biopsy of the enlarged lymph nodes is done to confirm the diagnosis. Treatment. The treatment is determined by the extent of the cancer. Small lesions, when identified early, can be removed and the cancer is cured. The rate of cure is less successful later in the disease when the cancer spreads to neighboring lymph nodes or metastasizes. The first line of treatment is radiation. The treatment of choice, if the laryngeal cancer is localized and in the early stages, is radiation. External or internal radiation may be used. Number 2, if the cancer is advanced, radiation may be used along with chemo to avoid a total laryngectomy. And 3, radiation may also be used after a laryngectomy to treat cervical lymph node involvement. The second line of treatment is chemotherapy. A multi-drug treatment regime is used. Chemo can be used pre-op. It may be used in combination with radiation. Radiation plus chemo has a higher cure rate than radiation alone. And lastly, chemo may be used to treat inoperable tumors that have metastasized beyond the head and neck, or for tumors too large to be removed surgically. The next type of treatment is surgery. The extent and type of surgery depends on the size of the tumor, the site of the tumor, and the invasiveness of the tumor. Small localized tumors and vocal cord polyps and nodules can be treated on an outpatient basis. Laser surgery is going to vaporize these tumors and the voice is preserved. Postoperatively, these patients should whisper so they can rest their voice for 1 week or more after surgery. Then there's a laryngectomy. This is removal of the larynx. It can be a partial laryngectomy, where 1/2 or more of the larynx, which again is the voice box, is removed. First, there is a partial laryngectomy. 1/2 or more of the larynx or voice box is removed. The patient that has a partial laryngectomy will eventually be able to speak, breathe, and swallow normally. The patient may have a tracheostomy for about 1 week post-op. The reason they do the tracheostomy is to keep the airway open. Once the tracheostomy is removed, the stoma will heal and the patient will be able to breathe, speak, and swallow normally. Then there's a total laryngectomy. That's the entire removal of the larynx plus the surrounding tissue. Normal speech will be lost. There is never going to be a time when this patient will regain the ability to speak normally. The patient will have a permanent tracheostomy or a permanent stoma because they will not be able to breathe through the nose. Their new airway will be at the trach level. There is no risk, the patient needs to know there is no risk for aspiration because the trachea and the esophagus are separated permanently by the surgery. Then there's what they call a total laryngectomy with a radical neck dissection. When the cancer in the cervical lymph node, when there is cancer in the cervical lymph nodes, a total or modified neck dissection is done. When a radical neck dissection is done, the cervical lymph nodes, the sternocleidomastoid muscle, the internal jugular vein, the spinal accessory nerve, which is cranial nerve 11, and the submaxillary salivary gland is removed. So all of those things are removed on the side of the neck where the tumor is located. Postoperatively, the patient that has had a radical neck dissection will have problems lifting and turning their heads, and their shoulder on the affected side is going to drop or droop. That's because of the extent or the radicalness of the muscle loss. So as you can see, laryngeal surgery to remove a tumor of the larynx is pretty radical. So best to prevent it. So health promotion. It is better to prevent and a lot easier to prevent laryngeal cancer than to treat it. The nurse plays a vital role in health promotion to help reduce the risk of developing cancer of the larynx. First, teach about the risks and dangers of smoking. Be proactive with children, teens, and young adults. Number 2, refer tobacco users to smoking cessation groups. 3, teach patients contemplating smoking cessation about the nicotine patch and Chantix. 4, promote alcohol cessation, or at the very least, alcohol moderation. And teach people about the early warning signs of laryngeal cancer. And explain the importance that if any signs and symptoms arise, they should seek medical care soon so it can be diagnosed and treated early. The nursing assessment is very, very important because the nurse often picks up on early clues that a patient has laryngeal cancer when doing a thorough, focused respiratory assessment. This is so important because manifestations of laryngeal cancer often are not recognized until the disease is advanced. So these are some things to ask your patients. 1, have they had any persistent changes in their voice, hoarseness, breathlessness, difficulty or painful swallowing, persistent sore throat or cough, ear pain, difficulty breathing, or the feeling of a lump in their throat? Find out about their smoking history. How many packs a day do they smoke? How many years has the patient been smoking? Alcohol use. Does the patient drink alcohol? If so, how much do they consume every day or every week? And how many years has the patient been using alcohol? What is your occupation? Do they have any exposure to noxious dust, like working with asbestos or coal mining? 5, assess their general appearance and health. Listen for hoarseness and coughing when the person speaks. Observe any swallowing problems. Inspect and palpate the neck, the lips, the cheeks, and the tongue for any masses, and inspect the neck for symmetry or asymmetry. It would be asymmetric if there was a tumor. Inspect the mouth and throat for white or red patches, and check for lymph node enlargement and tenderness. Next, we'll talk about pre- and post-operative nursing care for the patient undergoing a laryngectomy, which will segue into the overall nursing process. Even having benign laryngeal nodules removed is a frightening surgical procedure. Imagine being prepped for a total laryngectomy with a radical neck dissection. And so I'm going to hit on some of the main points, but please read your nursing checklist in the book. Preoperatively, determine the patient and family's level of anxiety, and they will be pretty anxious. Provide emotional support and meds afforded for the patient. Determine the patient family knowledge of the procedure. Being well informed and knowing what to expect helps alleviate some of the anxiety. Teach the patient and the family that after surgery, the patient will not be able to speak. The ability to speak will be lost. So teach the patient the use of alternate communication methods for the immediate post-op period, such as using a magic slate, paper and pencil, an alphabet board, a computer, whatever the patient feels comfortable with. Teach the patient and family that post-op the patient will have a permanent tracheostomy or stoma to breathe through, and the trach will need to be cleaned and suctioned periodically. Explain that nutrition will be initially provided via enteral feeding tube. The patient is not going to be able to eat for a little while. Once they are able to eat again, food will be introduced. Explain that post-operatively the patient will temporarily lose the sense of smell, and inform the patient and family that if a radical neck dissection is being performed, they will have trouble turning their heads and lifting on the affected side. Post-operatively, immediately post-op, the number one concern is maintaining a patent airway. Therefore, this seems like the best place to segue into the nursing process. Remember, the larynx is the narrowest part of the upper airway. Tissue edema in the larynx post-op may restrict the airway and compromise air movement and proper gas exchange. So the first thing you want to do is monitor for signs of airway obstruction, labored breathing, inspiratory stridor, restlessness, and anxiety. These can all be bad signs, and they are signs that the patient probably needs to be suctioned. Monitor the respiratory status frequently. Note the respiratory depth, the rate and pattern, and auscultate the lung sounds. Monitor the O2 sats. Report if they're below 95. Hopefully, parameters may be already established for when the nurse should raise the rate of flow on the oxygen. If not, contact the MD for orders. Oxygen will be humidified. The tubing needs to be kept clear and free of obstruction. And also monitor for oxygen toxicity. The head of the bed should be elevated, semi-Fowler's or Fowler's position. You can apply cold packs to the neck as ordered by the doctor. This is going to constrict the blood vessels, which will help reduce the edema. Call respiratory therapy, PRN. when you need help, and encourage deep breathing, coughing, and position change to facilitate mucus secretion. The second problem is nutrition. Immediately post-op, enteral feedings and IVs will be in place. Tube feedings and IV fluids will continue until the patient is able to consume adequate amount of food and fluid on their own. So you want to assess the patient's nutritional status. What is their weight, height? Have they lost weight? And if so, how much? What is their BMI or body mass index? Evaluate their diet prior to illness and establish their food preferences and dislikes. A nutritionist consultation is done to evaluate and educate the patient. The dietitian will evaluate their nutritional needs and deficits. Keep careful count of I&O, calorie count, and daily weights. Reassure the patient that once he begins to eat, he will not aspirate or choke because the trachea and esophagus were permanently separated during surgery. When initiating PO foods, start with soft food, not liquids. It's easier to aspirate on liquids. Not that they will aspirate, but they could start coughing and have the feeling of choking. Provide mouth care before eating. Bad breath and a foul taste in the mouth can suppress a person's appetite. Anyone's appetite it can suppress, but imagine this person that just is fresh post-op from laryngeal surgery. They're already at a risk for impaired nutrition. So try to make it as pleasant as possible. The patient may develop stomatitis or esophagitis after chemo and radiation. This makes it very painful to eat. You can apply topical anesthetics like viscous lidocaine before meal that will make it a little bit more comfortable. And the meal should be small and frequent with supplemental shakes between. Allow the person privacy when they're attempting to eat. The patient is embarrassed and self-conscious because eating is awkward. Pull the privacy curtain so that visitors and roommates aren't staring at them. Remember, initially the patient will have lost their sense of taste and smell. After a laryngectomy, it is difficult for patients to enjoy eating. Even patients who eventually regain their sense of taste will often say that eating does not have the same pleasure it used to. Next problem is immobility. So you want to be mindful of turning, coughing, and deep breathing, range of motion, and early ambulation. After radical neck surgery, the patient has lost muscle on the affected side, making it difficult to lift, turn their head, and keep their shoulder from drooping or dropping. So you want to teach the patient to support their head when moving up in bed. Teach the patient neck exercises to reduce shoulder drop and increase range of motion on the affected side. And thirdly, physical therapy should be initiated early, and it should be an ongoing, continuing thing after discharge. Infection. The tracheostoma is an open port to spread infection. Provide trach care, dressing changes, clean the incision, the inner cannula, and the flange or collar. Always clean it with normal saline, and I'm going to go over that at the end of this lecture. Protect the stoma from particulates or particles in the air with a gauze pad or a stoma protector, and suction the trach PRN using a sterile technique. The next problem is an altered body image and grieving. The patient who has had a laryngectomy or radical neck dissection has had mutilating, disfiguring surgery and has lost the ability to speak. It is no wonder that these patients are depressed and often angry. Having to deal with an extremely altered body image affects a person's self-confidence, and basic sense of self. So allow the patient and family time to vent. It is imperative that the patient know they have permission to feel the way they do. Otherwise, they're not going to be able to move forward towards coping and acceptance. Remain calm and supportive. Validate the person's feeling of loss, and let the patient know that you unconditionally accept their feelings. Never take what is said to you personally. Don't act defensive, hurt, or angry. The patient and the family aren't angry with you. They're angry with the situation. Allow the family privacy, but let them know you're available whenever you're needed. Do not avoid the patient because you feel sorry for them or cannot bear to look at them. Nobody wants to feel pitied. Refer to counseling and other support resources. There's counseling, there's the Laryngectomy Club, there's the Lost Cord Club, the VNA, etc. There are many services out there that you can hook families and patients up with. Restoring speech. It is a daunting task to regain speech after a laryngectomy. And after a laryngectomy, no one is ever going to regain normal speech. But the techniques that you need to learn to be able to form words are difficult to master proficiently. First of all is what they call a TEP, a tracheoesophageal puncture. This is the most successful option, and it is the most common option.
A voice prosthesis is a soft silicone device that's inserted into the tracheoesophageal fistula. You can see in this diagram here that it's a surgically created fistula that sits within the tracheoesophageal wall. So this is the front of the voice prosthesis that you can see when looking directly into the patient's stoma. And this is the back that sits in the esophagus when it's in situ. The voice prosthesis has a one-way valve at the back here that allows air to travel through for tracheoesophageal voice production, but remains closed at all other times to prevent leakage of saliva and fluids into the airway when a patient's drinking. You can see in this diagram, when a patient blocks off their stoma, usually by using their thumb or finger, air is directed through the voice prosthesis, which opens the valve door. The air then travels up through the esophagus and the pharynx, and it's the vibration of these tissues that we hear as tracheoesophageal voice. This voice is then shaped into speech using the articulators. The patients in the video were both using a low pressure voice prosthesis, but there are a number of different types. Some that the patient can change themselves on a regular basis, and others that can only be changed by a trained clinician. And these can stay in anywhere between 3 to 12 months before they need to be changed.
What happens is a small passageway, or a fistula, is surgically created behind the trachea and in front of the esophagus. Then a small one-way valve is inserted into the passageway. After the procedure, the patient will be able to force air from the lungs into the mouth by covering the stoma with a finger. Vibrations and sounds are created by the air. The patient is taught to use their tongue, lips, teeth, and palate to form the vibrations and sounds into words. The one-way valve also serves the purpose of preventing food from entering the trach. This is the best option and the most common, but sometimes it is not possible, maybe because the person isn't interested in having further surgery. Maybe they live in a remote area where they won't be able to get to this speech pathologist for training and help, or it just isn't an option because of the way that the surgery actually went. So there is another option known as the electrolarynx device. The electrolarynx devices are used to generate speech when TEP is not an option. These devices are battery operated. Vibrations and sounds are produced when the device is pressed against the neck or into the corner of the mouth. With the electrolarynx device in place, the patient is able to form words by using the muscles of the lips and tongue. And the third option, and the least successful, is esophageal speech. The patient is taught to use swallowed air and controlled belching to articulate sounds and form words by using the same muscles of the mouth and tongue that are used for normal speech. This technique is extremely difficult to learn, and only about 30% of patients are able to master it. Most patients are unable to resume any type of fluent speech using this method. So, continuity of care. Teach stoma care. Teach the patient to use a humidifier or a vaporizer in the home to add humidity to inspired air. You need the humidity in the air because now you aren't breathing through your nose, and your nose humidifies and warms the air. That won't happen naturally, so always have a humidifier. Number 2, teach the person to increase fluid intake to keep the mucous membranes moist and loosen secretions. 3, shield the stoma to prevent air particles from entering the lower respiratory tract with a stoma guard, such as a gauze square. Number 4, remove any secretions on the skin near the stoma promptly to prevent skin breakdown and irritation. Teach the person to protect the stoma with a cupped hand or washcloth while showering or bathing. Teach the person not to submerge the neck and stoma in water. So they don't want to be in a deep bath up to here, or a swimming pool, no water sports, things like that. Teach the patient lifting and moving the neck and head and shoulders will be more difficult. So to have continuing physical therapy and home exercises to strengthen the muscle they have left. Teach family and friends not to smoke in a patient's presence, and the person will need continuous speech therapy to master the new techniques of speaking. Before I end this lecture, I want to just review trach care. Review it in your book because I did skip over some of the preliminary parts like washing your hands, getting your supplies, things like that. I just went into the basic nitty-gritty of the whole procedure. So, trach care. You want to position the patient in semi-Fowler's or Fowler's position. Use a clean technique to remove the soiled trach or stoma dressing. Okay, so now we've taken care of the clean technique, wash our hands. Now we're going to set up our sterile field with a sterile bowl, sterile gloves, sterile dressing changes. So using sterile technique, clean the incision. Use 4x4s or sterile applicators, moisten with sterile normal saline. Remove the inner cannula and soak it in sterile normal saline. After the inner cannula has soaked, clean it with a small sterile brush, sterile cotton-tipped applicators, or sterile pipe cleaners. Whatever you have on hand that's sterile and will do the job. Once the inner cannula is cleaned, rinse it thoroughly with sterile normal saline, and then tap the inner cannula gently to remove the excess fluid. Then replace the inner cannula. Clean the trach flange or collar with sterile saline. Use a sterile 4x4s or a sterile applicator moistened in sterile normal saline. Then replace the trach and stoma dressing. Don't cut or use cotton line dressings because those frayed pieces of fiber may be aspirated into the respiratory tract and get caught in the stoma. Next, apply clean tracheostomy ties. Once the new ties are in place, and only after the new ties are in place, and the trach is secure, then you remove the old ties. You never want to take the old ties out first, because if the trach could be coughed out, and you would have a real disaster on your hands. And lastly is suctioning a trach. The person should be in the sitting or Fowler's position. Check the suction pressure of your suction setup. Make sure it's correct per orders. Lubricate a 10 to 14-inch French catheter with sterile saline. The catheter will be in a sterile packaging. Insert the cath into the lumen of the trach. Begin intermittent suctioning while slowly withdrawing and rotating the catheter. So you turn it around slowly and as you pull it out of the trach. Do not suction for more than 10 seconds at a time because the suction catheter is cutting off the airway momentarily. So you need to be quick. Let the patient rest and deep breathe before repeating. If more suctioning is needed, they need time to relax, deep breathe, and oxygenate the lungs. Repeat suctioning no more than 3 times in one sitting, and avoid unnecessary suctioning to prevent trauma to the airway and also to prevent foreign objects or bacteria for causing an infection.